So today the topic we are going to see is about the diabetes. It just gives a picture of the criteria, classification, and pathophysiology of the each diabetes or different types of diabetes, which are the important topic in ninth semester. As you all know, it's a group of metabolic disease that is a hyperglycemia, which is due to defect in the insulin secretion, insulin action, or both. The chronic hyperglycemia of diabetes is associated with long-term damage, dysfunction, and failure of different organs, especially the eyes, kidneys, nerves, heart, and blood vessels. So, before going into the proper pathophysiology, a few words about the normal homeostasis. So, normal homeostasis is maintained by two important hormones. One is insulin, which is secreted by the pancreas. Another one is glucagon, which is secreted by the alpha cells of pancreas. So, if there's high blood glucose level, what happens is beta cells release the insulin into the blood, so which act on the liver, which converts glucose to glucagon, fat and proteins, and act on the muscle to take up the glucose and convert to glycogen. So, normal glucose level is maintained, whereas in case of there's a decrease in blood sugar, the glucagon secreted will act upon the liver to convert glucose to glucose and increase the production of glucose in the blood, which leads to normalization of the blood glucose level. So the diagnostic criteria based on the blood glucose level, fasting, if it's less than 100 is normal. Pre-diabetes will be 100 to 128. Diabetes is more than 126. So in case of, if it is a glucose tolerance test, less than 140 is normal, 140 to 200 is pre-diabetes, more than 200 is diabetes. Coming to based on the HbA1c level, less than 5.7 is normal, 5.7 to 6.5 is pre-diabetes, more than 6.5 will be diabetes. So coming to etiologic classifications, commonly type 1 diabetes, which is due to beta cell destruction, which is leading to absolute insulin deficiency, which could be either immune mediated or idiopathic. Type 2 may range from predominantly insulin resistance with relative insulin deficiency to predominantly secreted defect with insulin resistance. So coming to other less common types, we have genetic defects of beta cell dysfunction. It's commonly called maturity onset diabetes in the young. We have different types. So coming to genetic defects in the insulin action, type A insulin resistance, leprachonism, Rabson-Mendenhall syndrome, lipotrophic diabetes, and coming to disease of the exocrine pancreas, pancreatitis, trauma or pancreatectomy, neoplasia, cystic fibrosis, hemochromatosis, and fibrocalculus pancreatopathy. So, what are other common endocrine dysfunction or endocrine diseases which can cause increase in blood sugar level? It's acromegaly, Cushing's syndrome, glucogonoma, pheochromocytoma, hyperthyroidism, somatostatinoma, and aldosteronism. So, what are drugs? Pentramidine, nicotinic acid, glucocorticoids, thyroid hormone, diazoxide, beta-adrenergic agonist, thiazides, dilantin, that is called phenytoin, gamma interferon. So coming to infections, congenital rubella, cytomegalovirus, an uncommon form of immune-mediated diabetes, Stifman syndrome, anti-insulin receptor antibodies. So what are other genetic syndromes? Down syndrome, Klinefelter syndrome, Turner's, Wolfram, Friedreich ataxia, Huntington's chorea, Lawrence-Moon-Medal syndrome, myotonic dystrophy, porphyria, and Prader-Willi syndrome. And fourth, not the least one but important one is the gestational diabetes mellitus. So if you observe this slide, it shows that there are different types of diabetes and they shows the glucose. What happens? There is a normal glucose level and what happens in hyperglycemia and what is the treatment requirement. Like if you take type 1, it could be from normal glucose regulation to impaired and diabetes mellitus, where insulin requiring for survival is very, very important. If you compare to other types where they require insulin to control. So any type 1 diabetes mellitus, we have to insist upon the early initiation of insulin therapy rather than prescribing the oral hypoglycemic drugs, and we have to reiterate that they need insulin for their survival. The risk factors in type 2 diabetes: older age, obesity, family history of diabetes, prior history of gestation diabetes, impaired glucose tolerance, physical inactivity, and race and ethnicity. But if you see in type 1 diabetes, risk factors is very less. Their main important thing which will be encountering will be autoimmune, genetic, and environmental factors that are involved in developing type 1 diabetes. So I want to talk few words about incretins. Nothing but it is one of the important hormones. The deficiency or resistance to incretin is noted in type 2 diabetic patients. Both the gastric inhibitory peptide and glucagon-like peptide 1 are released from the endocrine cells of the duodenum and jejunum in response to intranormal carbohydrate but not in response to circulating glucose. The stimulation of insulin secretion by both these hormones is dependent on the ambient glucose concentration, which is greater when plasma glucose concentration is high and absent when plasma glucose concentration returns to basal levels. If you have a look at this slide, you can see gastric peptide on one side and glucagon peptide on the other side. If you see on pancreas, this increases insulin secretion, increases the glucagon secretion, and decreases the beta cell apoptosis and increases the beta cell proliferation. So we have well control on the glucose. Here it is a glucagon-like peptide, so which increases the insulin whereas decreases the glucagon, but it will decreases beta cell apoptosis and increases beta cell proliferation. So which have both they have roles in the regulation of the keeping normal blood glucose level. The same thing, if you observe this slide also, we can see in type 1 diabetes there is an insufficient insulin. Here there is insulin resistance. So we have, if you see the insulins are very less, glucose are more. So if you see if their uptake by glucose, there is a diminished glucose uptake in the fat and muscle cells. Okay, which have a so we can see in this because of the insulin is very less, because it will initiate the glucose uptake. So because of less insulin, there is less glucose uptake. If you see the same thing here, there is insulin resistance. You can see so many insulin we have in the insulin receptor, is sitting on the insulin receptor, but there is a defect in the signaling the glucose this 4 receptor. So there is a decrease in the diminished or decreased glucose uptake in the fat and the muscle cells. So coming to type 1 diabetes, few slides we will see about the risk factor, the pathogenesis and clinical features of the type 1 diabetes. So what are environmental factors you can see in the type 1 diabetes? It's in genetically susceptible individuals. Exposure to one or more environmental agents appears to trigger an immune response, ultimately causes destruction of insulin producing pancreatic beta cells. So identification of these environmental factors is very important, so we can better understand the pathogenesis of the disease and also in developing strategies to prevent type 1 diabetes. So what are other factors? Viral infections, immunizations, diet exposure, especially exposure to cow's milk in early age can cause type 1 diabetes. Vitamin D deficiency, perinatal factors such as maternal age, history of preeclampsia and neonatal jaundice, whereas low birth weight decreases the risk of developing type 1 diabetes. So in this slide, if you see the pathogenesis of this type 1 diabetes, you can see the pancreas is normal, healthy islet cell which contains beta cells. With the role of this autoimmunity, because of cellular immunity, there is a gene that expands self-reactive cells, the genes that modify the immune function, genes that interfere with immune regulation, and genes that influence the beta cell survival. All these factors leads to destruction of this beta cell in the pancreas, which leads to autoimmune diabetes. So in this slide also we can see what are the important factors, that is perinatal and intrauterine factors, prenatal factors which can cause the islet autoimmunity, which leads to clinical type 1 diabetes. Postnatal factors like decreased breastfeeding, increased cow's milk exposure, vitamin D intake, decrease in vitamin D intake, increase childhood infections, increased obesity, viral infections can all lead to clinical manifestation of type 1 diabetes. So prenatal factors, genetic and HLA genotype also can lead to islet autoimmunity. So these are some important points that we have to remember in case of islet autoimmunity in clinical type 1 diabetes mellitus. So if you see this slide, it will show, it will give you a picture like what happens with beta cell mass over the time in case of type 1 diabetes mellitus. So you can see that in with the genetic susceptibility, with proper environmental trigger, leads to autoantibody insulators. Then later, which leads to decrease in beta cell mass or decrease in insulin level. So clinical onset of type 1 diabetes. And if you see the blood investigation, there will be loss of C-peptide, complete loss of C-peptide. So there is no insulin production at all, so which can lead to type 1 diabetes. So in this clinical presentation, just we will go through the what are the different ways the type 1 diabetes will present. So classic new onset, diabetic ketoacidosis, silent or asymptomatic insulin discovery. Hyperglycemia without acidosis is the most common presentation in childhood type 1 diabetes. Symptoms are caused by hyperglycemia, that people very well know. There is a polyuria, polydipsia, weight loss despite increased appetite, initially polyphagia and lethargy. So coming to polyuria. So when serum glucose concentration exceeds above 180, the renal threshold for glucose, which leads to increased urinary glucose excretion. Glycosuria causes osmotic diuresis, that is polyuria and hypovolemia. And polyuria present as nocturia, bedwetting or daytime incontinence in a previously continent child. So in this bedwetting, I would like to share one of the case I have seen in the medicine OPD before this COVID time, where that girl, she is around 14 or 15-year-old. She is studying in 9th standard. She came to medicine OPD along with the father. Her main complaint is bedwetting. So I called her father and asked again whether she is having bedwetting. He also confirmed that saying that she has that symptoms. That's why they came to consult the doctor. So luckily I asked for, though she didn't have other symptoms, so I asked to check the glucose. So the GMR was showing 500 milligram per deciliter. Then I told that girl and her father that she is having diabetes, and I told them to get admitted, but they didn't get admitted. Okay, they actually absconded. So, but this case I will not forget, because one of the we usually tends to see the patients with all polys, that polyuria, polyphagia, or sometimes they'll come with polydipsia, or they will be very emaciated. But this is a patient where that particular girl, she came with specifically with complaints of bedwetting. So this actually case actually taught me. So in case of any recent bedwetting, we have to also look into the blood glucose level. So coming to polydipsia, it's nothing but is a enhanced thirst because of increased serum osmolarity from hyperglycemia and hypovolemia. Coming to weight loss, it's a result of hypovolemia and increased catabolism. Insulin deficiency in diabetic children impairs glucose utilization in skeletal muscle and increases the fat and muscle breakdown. Initially, appetite is increased, but over time, children may become anorexic and contribute to weight. So coming to visual disturbances, because of high glucose, there will be alteration in the osmotic milieu of the lens, which are commonly seen. And to lesser extent, you have aqueous and vitreous humors leading to changes in diffractive index. Children with long-standing hyperglycemia are present with cataracts. Actually, usually we can see in our ward, actually with patients high blood sugar, they have problem with the vision. So if you send them to ophthalm OPD, they'll ask us to control the blood sugar. Then only they can give correct evidence if there is any problem with the refractive error or is really due to high blood sugar level. Association with other autoimmune diseases of this type 1 diabetes. As a thyroid autoimmunity is particularly common among patients with type 1 diabetes, affecting more than 1/4 of the individuals. Annual testing of TSH in children to detect early thyroid metabolic abnormalities. If anti-thyroid antibodies are present, example, anti-thyroid peroxidase, risk of hypothyroidism is greatly increased. So polyglandular autoimmune disease, especially type 2, which consists of adrenal insufficiency, autoimmune thyroid disease, and gonadal insufficiency along with type 1 diabetes. And third one, the transglutaminase autoantibodies are present in approximately 10% of patients, and half of these patients have high levels of autoantibody and celiac disease on biopsy. So there are three groups from the etiological point of view: autoimmune, idiopathic, and double. So the autoimmune group is represented by type 1A, which is polygenic and is most frequent type of this disease, corresponding approximately 80 to 90% of all type 1 diabetes mellitus cases. The other subtype of this group is LADA, that is latent autoimmune diabetes in adults, which appears after the age of 35 and is frequently associated with other autoimmune endocrine diseases. The third subtype includes called monogenic. They correspond to type 1 diabetes of the autoimmune polycystic syndrome type 1A and of IPEX syndrome, that is immune dysfunction, polyendocrinopathy, and enteropathy. So coming to type 1A, it's a chronic inflammatory disease which leads to selective destruction of beta cells in pancreatic islets. Such cells are affected by processes involving specific cellular and autoimmunity mechanisms against their antigens. A failure of regulatory T cells, otherwise called Tregs, this process is involved. Type 1B is also called idiopathic, or all the clinical features of type 1A, but the autoimmune component is not detected. Another is 1B subtype. It's a fulminant diabetes, most described in Asian peoples, mainly Japan, China, and Korea. A short clinical history before the first acute metabolic decompensation presents the impairment of, that is, beta and alpha cells of the pancreatic islet and no autoimmune etiology. Finally, the third one, the denomination of mixed or double, where there is type 1 plus type 2 diabetes has been proposed when we have the type 1A autoimmunity plus type 2 obesity, insulin resistance, dyslipidemia, diabetes characteristic in the same individual. What is LADA? It's otherwise called latent autoimmune diabetes in adults. Is a form of autoimmune. It's a type 1 diabetes which is diagnosed in individuals who are older than the usual age of onset of type 1 diabetes, usually more than 35 years. Alternate terms will be used for LADA is slow onset type 1 or sometimes also called type 1-5. The patients mistakenly thought to have type 2 diabetes based on the age, the time of diagnosis. So what are the features? Usually aged more than 25 years, clinical presentation masquerading as non-obese type 2 diabetes, initial control achieved with diet alone or diet and oral hypoglycemic agents. Insulin dependency occurs within months but can take 10 years or more. Other features of type 1 diabetes are you have low fasting and post-glucagon and C-peptide, HLE susceptibility alleles, islet cell antibody, glutamic acid decarboxylase antibodies. So about 80% of adults apparently with recently diagnosed type 2 diabetes, but with glutamic acid decarboxylase autoantibodies progress to insulin requirement within 6 years. The potential value of identifying this group at risk of progression to insulin dependence includes the avoidance of using metformin treatment and early introduction of the insulin therapy. So just to reiterate the few points in case of type 1 diabetes, where there is a genetic predisposition, environment, along with immune dysregulation because in like islet antibodies and insulitis T cell mediated, all can lead to beta cell destruction and insulin deficiency, where the cause will be, it could be normal to glucose intolerance to frank diabetes. Coming to type 2 diabetes pathogenesis, here you can see there is a genetic predisposition and environment factors. So multiple genetic defects can lead to primary beta cell defect, and obesity can lead to peripheral insulin resistance. So deranged insulin secretion, inadequate glucose utilization. All these things can contribute to hyperglycemia, so beta cell exhaustion, and type 2 diabetes. So type 2 diabetic subject manifests multiple disturbances in glucose homeostasis like impaired insulin secretion, insulin resistance in muscle, liver and adipocytes, and abnormalities in splanchnic glucose uptake. So coming to insulin resistance in type 2 diabetes. Here you can see the resistance in muscle and liver is a characteristic feature. The basal state, hepatic insulin resistance is manifested by overproduction of glucose despite fasting hyperinsulinemia, and this increased rate of hepatic glucose output is the primary determinant of the elevated fasting plasma glucose concentration. All the muscle glucose uptake in the post-absorptive state is increased, but the efficiency with which glucose is taken up by muscle, that is glucose clearance, is diminished in type 2 diabetes. And during insulin stimulated conditions, both decreased muscle glucose uptake and impaired suppression of the hepatic glucose production contribute to the glucose intolerance. So coming to role of what you call FFA, that is free fatty acids. It stores at triglycerides in adipocytes and serves essential energy source during fasting conditions. Its insulin is a potent anti-lipolytic hormone and restrains the release of free fatty acids from the adipocyte by inhibiting the enzyme called hormone sensitive lipase. The fat cells of type 2 diabetes will, if you see, they are markedly resistant to the inhibitory effect of insulin on lipolysis. And this chronically elevated plasma free fatty acid concentration cause insulin resistance in muscle, liver and impair insulin secretion, thereby increasing the plasma glucose level. So further, this slide is reiterate that increased free fatty acid causes impaired insulin secretion by beta cells of pancreas and cause the liver to increase the glucose production and makes the muscle to decrease the take up of the glucose. All will lead to increase in the blood sugar level. What is this harmonious quartet? It's nothing but the hyperglycemia lead by 4 important factors. Like if you see, decreased insulin secretion by the pancreas, decreased glucose uptake by the muscle. So that is lead to hyperglycemia. Increased hepatic glucose production and increased lipolysis. All the 4 things will lead to increase in the blood sugar level. So coming to maturity onset diabetes of the young, what is mean by MODY? So what is a fault in the genes which lead to maturity onset diabetes of the young? So it's a heterogeneous group of disorder characterized by non-ketotic diabetes mellitus. It's an autosomal dominant mode of inheritance. It's usually onset before age of 25 years and frequently in childhood or adolescence. There is a primary defect in the function of beta cells of the pancreas. The mutation in one of the at least 6 different genes. See, all these genes are expressed in beta cells and mutation of any one of them leads to beta cell dysfunction and diabetes mellitus. The factors that affect the insulin sensitivity such as infection, puberty, pregnancy and rare cases obesity may trigger the onset of diabetes and increase the severity of hyperglycemia in patients with MODY. So coming to pathogenesis of maturity onset diabetes, in this diagram you can see there is a glucose which is taken by the beta cell by means of glucose transporter or by means of enzyme glucokinase. It's converted to glucose 6 phosphate glycolysis which lead to generation of the ATP. So ATP sensitive potassium channel closes. This leads to depolarization of the calcium channel which causes the insulin content granules to secrete where there is an involvement of the nucleus with the enzymes. So any defect in these factors can lead to beta cell dysfunction, and this is the pathogenesis of the maturity onset diabetes of the young. Important enzymes or genes that could be in defect. So what are the important clinical features which differentiate between MODY and the type 2 diabetes? Here it is a monogenic inheritance with autosomal dominant. Here it is polygenic. Age at onset will be less than 25 years. It is adulthood in type 2. Multi-generational MODY, rarely multi-generation type 2. Penetrance will be 80 to 95%, whereas is variable. You can see MODY is seen in non-obese and type 2 is also usually seen obese. Metabolic syndrome will be absent in MODY, whereas usually present in the type 2 diabetes. Screening and diagnosis of gestational diabetes mellitus. So when do you screen and what test would you perform? So perform a 75 grams oral glucose tolerance test with plasma glucose measurement fasting at 1 and 2 hours. At 24 to 28 weeks gestation women not previously diagnosed with overt diabetes. It should be performed in the morning after an overnight fast of at least 8 hours. Its diagnosis of GDM is made when one of the following plasma glucose are exceeded, like fasting more than 92, 1 hour more than 180 mg per deciliter, 2 hours more than 153 mg per deciliter. So a 42-year-old asymptomatic man with hypertension presents for his annual physical examination. His medications include atenolol combined with clothianidin. Both parents are type 2 diabetes. He does not smoke cigarettes. His BMI is 32.3 and his BP is 130/80. Question is, would you screen the patient for diabetes? If so, how? So what are the screening criteria? So consider testing for diabetes for all people aged 45 years and older. If normal, repeat testing every 3 years. Testing those below age 45 or test them more frequently if they are at high risk of diabetes, including those obese, family members with diabetes, members of high risk ethnic groups such as African Americans, Hispanics, or American Indians, or a female who delivered a baby weighing 9 pounds or diagnosed with GDM, hypertensive, and with blood lipid abnormality.